Hey everyone, Dr. Kuniak with a weekly video lecture. So I was trying to make some decisions around what I wanted to have for this video lecture as opposed to what I want to have in our next live class meeting. And so two things came to mind for me. One is we're not meeting next week because it is week 8, and so that is our self-care week, and so that means it's going to be 2 weeks until I see you all again. And so I wanted to go over the biopsychosocial assessment tool and some pointers for that in our next live meeting, but I feel like that's going to be a long time before I can get to that. And the other thing is, then I was preparing this lecture and kind of coming up with some client examples that I wanted to share, and it struck me that I could just kind of share the biopsychosocial in this format, and then I could talk a little bit more about the client examples in our live class meeting, and that might line up better. So that's what I'm going to do now. Is I'm going to talk a little bit about the psychosocial assessment, what that looks like, so that you have some time and you can ask me some questions about it before you actually have to do the assignment, um, and then we can have some case discussion at the next live meeting. Okay, so I'm going to try to bring up my psychosocial. Let's see. There it is. Let's see if this works. Again, I'm testing out new software this semester. So, okay, looks like it's rolling. So this is in D2L for you. It's in with the other assessment tools in the assessment tool resources folder under content. This psychosocial assessment is something that I developed. I based it off of other psychosocials that I have used in the past. Technically, it is biopsychosocial. I am so used to just shorthand calling it psychosocial. That's what I labeled it. Same thing. It is the same thing. Um, but so you can save this, save a copy of this, and keep it for your own information. I actually encourage you to save all of the assessment tools that I have pulled together for this course, because you never know when one might be useful for you, and you can just download the PDF files and hang on to them. I keep a folder of assessments on my laptop, and when I'm working with a client and something comes up, I already have it. Then I don't have to go looking for it. So this gives you a leg up. That's part of my idea here. But so the purpose of a biopsychosocial assessment, these are very common in counseling agency work, in small group practices, and so as a result, like private insurance companies and so on and so forth want you to have these too. Typically, they want you to use some form of this, some sort of a primary assessment that you can use with a new client. And so I think because so many of us have the experience of working with a biopsychosocial in our agencies when we start off, when we're in our field experiences, and then when we transition into our own practice, we kind of model our assessment tools over what we've seen. So this is the basic format of it. It's very common to have just name, date of birth, age, client ID. When I started off in the field, this would have been social security number. We don't do that anymore. It kind of shows how we've evolved over time. So a client ID number is typically whatever you assign to the client. My ID filing system was just to take the first initial of their last name and then put 00 whatever number after it. So like if I had John Smith and they were my first S client, it would be S001. And then if I had Judy Stevenson as a next client, it would be S002. Um, you could do JS, you could do whatever, however you want to do it. Just keep a consistent ID system. Your agency or practice may already have a method of assigning client IDs. The insurance companies like that for tracking purposes, and again, so you can kind of keep some of the confidential information confidential and just send this as the standard, just so you keep track of your method and use it. Intake date. I listed my outpatient practice here. Again, you can use this form and just change that for yourself. Uh, there are many ways to do a biopsychosocial. This is just the way that makes most sense to me. I've seen them in different forms and formats, and I'd encourage you to Google and see what else is out there too. But I think it's pretty customary to have the presenting problem listed early on um, as kind of a narrative. I was just at the dentist earlier this week, and they had a very similar checklist system to this, so I think it's kind of common. It's just instead of like having them narrate out their entire mental health history, these are some pretty common things that you would see, and so it's do you have this? If no, zero, and if so, what is the severity of it? Sometimes folks will also write. I just realized I have an end parenthesis there, and I'm not sure that I have it elsewhere. Oh well, typo. Um, Sometimes folks will also then ask duration. There is never enough room down in these areas, so a lot of times I would print these out, and then I would go over this with the clients, and I would just tell them to indicate to write on the back of the form or whatever the case may be. If you're doing it in electronic format, they can just add more space. But yeah, you want to get kind of an idea of typical symptoms, and then frequency, intensity, and duration are the typical things we look for there. That's hanging. That's not the best formatting, but it's probably when I switched it over to PDF, it removed some of my spacing. This is important for our diagnoses. This is not something that I saw at the dentist's office, for example. But if you look at the DSM and you see, you look at diagnoses, one of the qualifiers for whether or not something meets the criteria for a diagnosis is whether or not it has a negative impact on the person's life. If they're worrying a whole lot, but it's not really impacting them, technically it doesn't meet criteria for a diagnosis. Now, there may be other things that are pushing it, out into the forefront. But I think it's helpful to have a statement like that. So, like, this is going on. What's it doing? That helps us to determine severity too. I saw this on a previous psychosocial, and I like the question. So, if you've had previous mental health treatment, what was it, and how did it work for you? If something worked, we want to do more of it. If something did not work, we may consider avoiding that. It's also possible that it just wasn't implemented correctly, and we may still want to do it. And I have stories about that that we can talk about. But I think that that's important. Have you been hospitalized? No. Yes. Please describe. And then the bio part of the biopsychosocial is it's helpful for us to get a medical history. Um, Physical health symptoms are going to play into mental health symptoms and vice versa. So we want to kind of tease some of that out. I've said before, if my client comes in and is talking about depression symptoms, it's one thing if they don't seem to have anything else going on, but the depression is there. That's fine. That can happen. Depression is insidious. It can pop up for no reason. Someone can feel, completely devoid of hope, have lost lost their desire to live, and that can be without any other concerns. And that can be problematic too because people in their life will look at them and say like, you have no reason to be depressed. That's also depressing, and it's not helpful. But so if somebody is struggling with a significant medical disorder and they're depressed, that's not saying that we want to leave the depression there. We still want to work on it, but it makes sense. Like that is an adaptive response to us, to some sort of significant harm. When I shattered my leg years ago and I was in the hospital, I was in my early 20s and I couldn't walk. I was fairly depressed. It was, manageable, and it was, only for that time period. And when I was able to get my life back and sort of move around freely, it dissipated. But it was an appropriate, I think, reaction to here I am in my early 20s and I'm in a wheelchair for a period of time. I shattered my right femur, car accident. It was rough. Again, story for another time. But so it helps us to know. It helps us to know what's going on in the person's life because maybe their symptoms are related, or maybe the physical health symptom takes precedence over the mental health symptom. Significant family medical history, that can relate. Sometimes diagnoses run in families. Sometimes the diagnosis of someone else can be causing the diagnosis in our client. Any other health information that might be helpful for us to know. Again, this is a formatting issue. I'm sorry about that. This should be moved on to the next page. Helpful to get medication information. There is often never enough room for all of this. If somebody's prescribed medication, you don't save space. So again, I've had clients say like, "Can I bring you a printout of my medications and dosages and stuff, and I'll just attach it to this form, or in an electronic management system you can scan it in. A lot of times, just make a notation that it's on another page." Um, Pain of any kind is important to assess. Physical pain can cause mental health symptoms. There are instances of physical pain that is related to a medical reason resulting in mental health problems. There's also essentially phantom pain, pain that is coming up that has no other cause. If someone is in pain, we want to refer them to a medical doctor to rule out any sort of physical health problem before we presume that it's just psychosomatic. But we want to assess it and then make some decisions around it. When I was in family based, we would ask this question: do you have guns? I don't know if my cursor is showing up on the, yeah, it is. Do you have guns in your home? Partially because we wanted to assess their accessibility if they became depressed to a method to quickly take their life. Also for our own safety. So um, it's just helpful to know. I live in Western Pennsylvania. A lot of gun owners out here. I have no judgment one way or the other about people's gun ownership. I just believe that we should be responsible with it, and so it's helpful to know what's going on so we can at least have that on our radar. I've had clients who've refused to answer it, and then depending on the circumstances, that will depend on my decisions as far as being able to work with them or not. Have you ever engaged in any of these sort of binging or purging sorts of behaviors? Have you ever picked at your skin, pulled hair, had intrusive thoughts? These are all anxiety related symptoms for the most part, but it's helpful to know. Marital social relationships. This is the social part of the biopsychosocial, because our behaviors don't exist in a void. So you want to gather all of this information. Single, in a relationship, married, divorced, separated. How many times have you been married? I'm missing questions here that could probably be asked. There's probably other information. You can make a psychosocial as detailed as you want it to be. This is a 7-page psychosocial. I have worked with double this amount of pages or even more in a psychosocial. You can make them as detailed as you want. Children, how many? Please list their sex and age. You could also then filter this into a genogram, which we're going to go over. What do you do socially? That's helpful information. Family history. Talk about family of origin. Talk about relationships in the family of origin. It's sometimes helpful to know how people define the relationships that are going on in their household. What does it mean to be a mother? What does it mean to be a father? Even if you're not. What did you learn about these roles based on, your life at home? Any history of mental health or substance abuse problems in the family. We've kind of covered that a little earlier with diagnoses in the family as far as mental health, but it's still, I like to ask it in greater detail here. Any sort of traumas, some information about educational history, some information about work history. Again, this should be on the next page. Sorry about that. Substance use, if they're casual users, fine. If they're using it more frequently or in more severity, helpful to know. Substance abuse is important to substance use and substance abuse and addiction, all on a continuum there, are important factors to consider because substance use, before we render a diagnosis, substance use has to be considered because certain substance uses can account for the symptoms or behaviors better than a mental health diagnosis. So if there is substance use, we have to consider that before we rule in another diagnosis. Have you experienced blackouts? Have you used illicit substances? It's important to ask these questions and to get the information and be non-judgmental about it. People are coming for help, but it's also important to get the information. Date of substances last used, triggers, etc., etc. Any other pertinent information that this counselor should be aware of. You would type your name there, so like I would type my name underneath and then use sign and date. You can then, I'm going to pull this down. So again, that is in, there we go. That is in the D2L shell under the resources, assessment resources tab. If you're having trouble finding it, let me know. I think I've also probably got it in the weekly modules. For the biopsychosocial assessment assignment, you can use this biopsychosocial. You can use one you find online. You can use one you're familiar with. I'm okay with any of it. The goal of this and the other assignments where you're trying out assessments are to really get a feel for what information can you gather from doing this assessment and what else might you want to use, because no one assessment is going to meet all of your needs all of the time. A biopsychosocial is a really good place to start, though. You're covering a lot of bases and getting some information about a bunch of different topics so that you can then use that to dig a little bit deeper as you start to figure out what's going on. It is possible to render a diagnosis based on a good, solid biopsychosocial assessment. You may have to do that for your first session and to get the diagnosis done. But I would also be curious what else you might want to use. So that is one of the questions in the reflection form is, so you complete a biopsychosocial, what other things might you want to have on the radar, on your radar, for maybe another assessment tool that you want to pick up based on the stuff that you've looked at this semester? You can say, I want to have a suicide assessment on hand, just in case. I want to have a good depression and anxiety inventory on hand. I've had students in the past who really feel passionately about one area of the field or another. And so I'm just kind of curious, what other assessments would you want to try to put in, an opening case paperwork packet, whether that be physical packet or online packet, to just kind of have waiting in the wings. What do you think is missing from this that you would like to also assess? It's just opinion related. There's no right, wrong, or anything like that to it. But I just want you to kind of think globally about what can this assessment capture and what's it good at and what's it limited to that you might want to also take a look at. And again, that's all of the assignments this semester. I realize that assessments may be new to many of the folks in this class. And I think when I was starting off in the field, I had this belief system that I would do the assessments that were assigned to me. The client would present with anxiety related issues or something like that. And so I would do an anxiety assessment, and, my agency or practice would have one in mind for me. And sometimes they do and sometimes they don't. And so you have to make some decisions about, okay, no one seems to have a good assessment of attachment. Where am I going to find that? And, I have this inkling that maybe that's something I need to look into too. Where am I going to find that? What's good? What's not good? That's what I want to try to make sure you leave this class with. The other thing that I want to point out, and this is what we're going to talk case-wise when we get back to a live meeting, is even with assessments like this, it is possible for your client to lie to you. It's possible for them to misinform because they're embarrassed, they're afraid, they're afraid of what you might do with that information. They're afraid that you might judge them with that information. It's just somehow shameful to them, and they just don't care to share about it. They don't feel comfortable enough with you yet. I have several stories about clients who have either withheld the information, skirted around the information, outright lied to me about the information, and so I'm there trying to figure out what is going on with this case and where are we going and why are we not making any progress. And there's a big secret that has not been shared with me. I had my licensing supervisor used to say to me, he would say something like, well, Steve, you're pretty smart. And that's nice of him to say. If you can't figure out what you need to be working on in this case, it's probably not your fault. Some information is probably missing. So I'm going to say this to every one of you in this class. You're all pretty smart. And if you can't figure out what's going on in the case and what the client is really needing your services for, it's probably because you're missing some information. So I have become very comfortable with saying, do you feel like we're making progress here? And if the client says, not really, I'm comfortable with saying, yeah, I feel that way too. I don't feel like we're making the right amount of progress. I feel like something is missing. This is what I think this is what I am aware is going on. These are the flags that are popping up that are not telling me, that are informing me that I don't know enough. What's missing? When did these symptoms start up? What are these symptoms related to? something is out there that I don't know, that you may think is completely irrelevant, or you may be embarrassed about or upset about, or whatever the case may be, but I can't help you unless I have everything. So what am I missing? Sometimes a speech like that gets what I need, sometimes it doesn't, and it takes a little while longer. And I keep looking at my list of stories that I want to share with you, and I have a couple doozies that I'm really looking forward to sharing with you and getting your feedback and your reactions on. But I'm going to save that for our live meeting. Hopefully, this was helpful. Excuse me, I'm getting over the. I'm almost out of the woods. I think with my sinus infection cold thing. But anyway, I I think that covers everything that I need. My hope was that this helps you to continue to think about the assignments in a meaningful way. Hopefully, this helps you to think about the utility of a biopsychosocial assessment and why I would want you to do one as part of this assignment. And if you have any questions, comments, or concerns, I hope you reach out to me. Have a nice week off there, and uh, enjoy some self care. And I will look forward to seeing you all in our next live class meeting a few weeks from now. Okay.